Hi everyone, I am Boris Vabson. I'm a PhD candidate in the BEP department at Wharton. And today I'll be talking a little bit about managed care's impact on utilization. So while pretty developed literature exists on managed care's impact on the prices charged by providers, much less is known about managed care's impact on treatment composition, treatment quantity, as well as treatment outcomes. And today I'll be looking at this question in the context of Medicaid. And in particular, I'll be looking at the impact of Medicaid managed care on utilization among disabled Medicaid enrollees. So why disabled Medicaid enrollees? So first of all, this population makes up about 40% of all Medicaid expenditures, even though they account for about 15% of enrollees. In addition, a lot of states are currently considering shifting this population from Medicaid fee-for-service to Medicaid managed care. And for the most part, most states have not yet done this. Especially little work has been done on the impact of managed care on high-cost populations, such as this one. And given that this population experiences far less churn into and out of Medicaid than is typical for the program, that simplifies analyses quite a bit. So in addition to its pretty apparent policy relevance, this project has more general motivations. So it can help get at the efficiency impact of managed care, whether managed care ultimately is able to improve the efficiency of care, and possible mechanisms through which it might do so, and also get at whether managed care might have heterogeneous impact across patient types, whether it might work better for certain kind of patients than others. So even though this question of managed care is a pretty classic question in the literature, it hasn't been extensively examined for a couple of reasons. And one is data availability issues. So managed care has typically been this black box, and it's been hard to get at what actually goes on in these plans. And I address this by linking two unique administrative data sets for the state of New York for the 1999 to 2009 period. So one data set comes from CMS. It's the Medicaid Max personal summary file. And the other data set is New York State hospital discharge data at a discharge level covering inpatient as well as outpatient hospital activity. And so by linking these two data sets together, I'm basically able to track hospital utilization at a person level across the fee-for-service as well as Medicaid managed care settings, to do so across time and to focus in on specific groups of Medicaid enrollees in doing so. So in addition to this data availability issue, there's also been the issue of selection into managed care. And so it's been hard to disentangle the impact of managed care from the characteristics of those who are potentially in it. And to bypass this issue, I leverage managed care enrollment mandates that were introduced in New York State throughout the period that forced certain groups of people, including disabled Medicaid enrollees, from Medicaid fee-for-service into Medicaid managed care if they weren't already enrolled in Medicaid managed care. And these mandates, they were staggered across years, across counties, as well as across eligibility groups. So I want to talk a bit about my results. So I'm finding a very substantial decrease in hospital utilization as a result of Medicaid managed care implementation for this population. And this decrease in utilization is mostly occurring along the intensive as opposed to extensive margin. So while I'm seeing about a 10% decrease in the number of hospitalizations, I'm seeing about a 35% decrease in the total number of days spent in the hospital. And so while there might be a possible utilization offset going on, so potentially less inpatient care and more other types of care, I'm not seeing it in terms of outpatient hospital utilization. So while I'm seeing this huge change in inpatient hospital utilization, I'm seeing no change in terms of outpatient hospital utilization. So these results, they're robust to the use of various control groups. They're also robust to possible compositional changes that might be occurring to Medicaid enrollment throughout this time period, because I'm looking at a fixed sample. I basically construct a sample of people who were in Medicaid at the time that these Medicaid managed care mandates began, and I follow these people across time. So the next step here is really understanding the mechanisms that could be driving these utilization changes. And basically, particularly the extent to which these are driven by demand shifts across providers, as opposed to potentially changing behavior from pre-existing providers. And I've looked at this at a hospital level, and I'm finding that while patients are being sent to different hospitals, to some extent, that this does very little to explain the huge reduction in utilization that we're seeing. So as a next step, I plan to look at possible changes to providers used at the physician level, and whether or not there might be within hospital changes to the physicians used, and whether or not that might explain some of the reduction in utilization.